Hey everyone, we are going to be doing our biliary pathology on this module. This means we are going to be talking about some conditions and pathologies that are specific to the gallbladder, but then also to the biliary tree and the biliary system. As we know, the biliary system is so closely related to our liver, so we're going to kind of be touching upon some of those topics that we have mentioned in previous lectures. So let's get started. We are going to be talking about our gallbladder specific conditions first. One of the most common things that we are going to be seeing as a sonographer when we are doing abdominal exams is going to be what we call cholelithiasis. This is the medical terminology that we should be using for what are also known as gallstones. So these are these pesky little accumulations of bile components, cholesterol components, calcium components, and they form these rock-like or stone-like structures that sit in the gallbladder. Now, these typically do not pass. Kidney stones are very similar in this sense, where they form in the same type of fashion, but kidney stones we can actually pass. Gallstones we can't. So once we have a stone in our gallbladder, it's pretty much going to be with us for life unless we get our entire gallbladder removed. So pretty unfortunate once we see one. Chances are we'll be getting more over the course of the next few years or over the span of our life, but those gallstones are going to stay with us unless we have it surgically removed. Now, there are a specific type of population of patients that are more prone to get cholelithiasis, and that is going to be classified as the 5Fs. I don't necessarily agree with this, but we have a prevalence of seeing cholelithiasis more in women who are 40 or older, who are fertile or they've had children in the past, who are overweight, and who are fair in nationalities. So this is the patient who is most likely going to be coming in for gallstones. I have not noticed in my clinical experience any prevalence of that. We typically see a lot of male patients with gallstones, so I don't necessarily know how accurate that categorization is. In today's modern society. Also, if you are a diabetic patient, you are going to have a higher risk of kind of growing these gallstones. Also, any history of pancreatitis or parasitic disease, or if you have any type of infection that has affected your biliary tree of some sort, you are more prone to create a gallstone because of that. Clinically, some patients can be asymptomatic. They don't know that they have a stone in there. It doesn't bother them at all. But usually we're going to see patients complaining of some type of pain or discomfort. They're typically going to have biliary colic. And what this means is that usually after they eat, they're going to be experiencing their symptoms. These symptoms are going to commonly be right upper quadrant pain and pain that can radiate to their right shoulder. This is very concerning in terms of clinical presentation because if you have a patient coming to the ER who is complaining of right shoulder pain, the first thing they want to do is rule out that you are not having a heart attack or that you are having a heart attack, because shoulder pain is a very common symptom of heart attacks in a lot of patients. So we can very easily confuse the two if we're just talking on a clinical sense. This is where imaging is so important. Also, our patients can present with jaundice depending on if these gallstones are obstructing. They are also going to have abnormal LFTs, and depending on the severity of these gallstones, if it is causing some type of inflammation or infection of the gallbladder or the biliary tree, they can present with fever and chills. On ultrasound, we're looking for a pretty classic type of appearance, and that is going to be our classic triad. So this means that a gallstone is pretty much always going to appear as hyperechoic with shadowing, and they are going to be mobile. We need to know that that stone moves in that gallbladder to prove that it is in fact cholelithiasis. Another thing that we are also seeing a lot in cases with really large gallstones or gallstones that are causing the gallbladder to contract on that stone is our WES sign. So this stands for wall, echo, shadow. And that's exactly the order of what you are going to see in these cases of a really large or a contracting gallstone. Our first line is going to be the wall of the gallbladder that we see. It's going to be echogenic. Our second line is going to be the hyperechoic border of our stone. And then directly after that, we are going to be seeing our posterior shadowing. So we are going to see the wall, the echogenic stone, and the shadow. Wall, echo, shadow, sign, west sign. We also see sludge in a lot of cases of cholelithiasis. So we want to make sure that if we are seeing sludge, that we are evaluating that sludge and making sure that there are no actual stones that are hanging out in that little pool of debris. So let's take a look at what some of the classic appearances of cholelithiasis can look like. Up on our top left picture, this is going to be a very common presentation, and this is more of what we call gravel, where these gallstones, there are so many and they're so tiny that they're all kind of just pooling together. Remember, gallstones are going to be gravity dependent, so if our patient is standing, they are going to layer at the bottom of the gallbladder. If our patient is laying flat, they're going to layer at the posterior aspect of the gallbladder. If we have our patient laying on their stomach, they're going to layer at the anterior aspect of the gallbladder. So this is going to be an example of multiple tiny echogenic punctate stones that are sitting and layering in that gallbladder. Just to clarify, these are stones, all of these little guys in here, right? And we're still seeing them hyperechoic, and we're still getting extensive shadowing behind them. Our picture underneath that, bottom left, this is a pretty obvious sonographic appearance of cholelithiasis. We see 3 gallstones here, right? We have 1, we have 2, and we have 3. They're all shadowing, they're all echogenic. We can't prove that they're mobile because we're obviously not live scanning, but we would assume that these are mobile to get the diagnosis of cholelithiasis. Picture on the right side, this is probably what just one single solitary gallstone is going to look like. We can see the hyperechoic border and the posterior shadowing. And this top picture, top right, this is our west sign, our wall echo shadow. This gallstone is so massive that it is occupying the entire lumen of this gallbladder. And the gallbladder wall sitting right around it is contracting around that stone. So in cases of this, it's really important to get a very clear patient history, especially when you are first starting out. You guys are going to have a hard enough time trying to find a normal gallbladder while you're scanning, never mind a gallbladder that's trying to play tricks on you. When you are scanning through this region, you're looking in that main lobar fissure, you're looking for that anechoic dilated gallbladder, and all you see is shadowing in that region. You're probably thinking one of 2 things. You're probably thinking, my duodenum's full of gas and it's blocking my visualization of where the gallbladder should be. Or this patient had their gallbladder removed. And that's not neither of those are the case when we have a West sign. This gallbladder is so contracted along this entire large gallstone that we are not seeing any fluid-filled lumen of this gallbladder. This gallbladder does not have bile in it. This gallbladder is not going to be functioning properly, and chances are this patient has a lot of pain and discomfort. Next, we have sludge. We've talked about this a little bit in lab, and we just talked about it briefly a few slides ago, but this is going to be slightly different than a gallstone. This is going to be made up of similar components, but we're not quite a solid stone yet. This is made up of the calcium, the bile cells, the cholesterol cells, but we're a little bit more viscous. We're a little bit more liquefied than a gallstone or cholelithiasis. So this is when our bile starts to kind of get stagnant in our gallbladder. This particular region of bile, for some reason, hasn't been excreted during digestion. So it's kind of just hung out in the gallbladder a little bit longer than it should. So it's starting to get a little bit stagnant. There's some stasis to it. So that's why it's getting thicker and thicker. Clinically, patients don't have any symptoms with this. It's going to be mobile, meaning as we have that patient move, we're going to see it start to kind of slug its way down or up in the gallbladder, depending on gravity. It's going to layer in a dependent pocket or portion of the gallbladder. There's never going to be any vascularity to it because it's not a tumor. Arnold Schwarzenegger, it's not a tumor. It's going to be homogeneous with low-level echogenicity. So it's going to have the similar behavioral characteristics as a gallstone in terms of it moves, it is dependent on gravity, there's no blood flow to it, it's not concerning. But with something like this isn't causing the patient any pain, it's not preventing the gallbladder from doing its job. It's just a little bile that's kind of gotten stuck in that gallbladder for a little bit too long, longer than it should have been. Next, we have a sludge ball. So this is basically when sludge decides to take a very circular shape. And it is, in fact, just regular sludge, but we need to be aware that sludge can take on this appearance, and we need to know that we're not going to confuse it for a mass or a polyp. When we have a sludge ball, we're really relying heavily and we're dependent on the patient position. So we want to watch it. We want to watch it move in there. We want to watch it change shape if it does, so that we're proving that this isn't some type of circular mass in the gallbladder. Next, we have polyps. Unfortunately, my first picture didn't really convert over in this PowerPoint, so I'll try to throw a few more on the module for you guys to be able to evaluate them. Similar to gallstones, polyps can take on multiple different types of appearances. These are typically going to be benign findings, but we tend to watch them a little bit. We just want to make sure that they don't grow. If a polyp grows larger than 3 millimeters, then we need to kind of figure out our next steps. Do we want to do a biopsy of some sort? Do we want to remove that gallbladder completely? Are there any other signs of malignancy elsewhere? So we keep an eye on polyps, whereas gallstones, we don't really keep an eye on them unless they become super problematic for the patient. Polyps can very easily be confused with sludge balls and with cholelithiasis. The difference is that they are not going to move when we move our patient. They are not gravity dependent. They adhere to the wall. They actually originate on the wall. So they are not going to move or change position. A lot of polyps will be, yes, attached to the wall, but some of them can kind of hang into the gallbladder lumen a little bit more, and they're attached by a stalk, or what we call a pedicle. I'll try to put a picture of that type of diagram in the module as well, so you can kind of see what that looks like. We can have one polyp, we can have multiple polyps, we can have polyps for a bunch of different reasons, right? We could have had some type of gallbladder inflammation that led that gallbladder wall to kind of rapidly proliferate, and that's why we have this polyp. We could have a patient who has higher cholesterol levels than they should, and that caused the gallbladder wall to proliferate a little bit more. And sometimes we can have it for idiopathic reasons, and that would be an adenomatous polyp, where for some reason that functional tissue of the gallbladder wall just decided to keep proliferating in that region to create this little outpouching of tissue. On ultrasound, they are going to be echogenic. They are not going to shadow. These are not super dense structures. Cholelithiasis, super dense. It's made up of calcium, right? It's calcified. These are not. These are just made up of the gallbladder wall cells. So these are not going to give us any type of shadowing. We are not going to see these move, as we said, and they are typically going to be located towards the fundus of the gallbladder, but we can see them really in any location. Next, we have cholecystitis. So as we know, any type of itis means typically inflammation and or infection. So this is going to be the inflammation of the gallbladder itself. It's usually going to be caused by some form of an obstruction. So the most common cause of cholecystitis is going to be cholelithiasis that is blocking the gallbladder. So say we have a gallstone that's lodged in that neck of the gallbladder, and the gallbladder can't get that bile out, and it doesn't know what to do. It has this backup of bile fluid. This is going to cause the gallbladder to become inflamed. So that's going to be the reason for most cases of cholelithiasis. There's some type of stone somewhere blocking the normal function of that gallbladder. Most common in women, 40 to 60 years old. Going back to those 5 F's, obviously, if you are more prone to have a gallstone, and a gallstone is the most common cause of cholecystitis, well, then you are also going to be the most likely patient to have cholecystitis. Clinically, the presentation of cholecystitis is going to vary on the extent of this inflammation, the cause of this inflammation, the duration of this inflammation. But we never want to take cholecystitis lightly. These cases can progress rapidly. So if we're seeing cholecystitis, we need to get immediate medical attention. And we'll talk about that a little bit more on our next slide. On ultrasound, our gallbladder is going to appear dilated. So we're going to see a really, really large gallbladder. The wall is going to be thickened, so it's going to measure greater than 3 millimeters in AP diameter. The walls can start to appear irregular, and we can actually kind of start to see some pericholecystic fluid around the wall. Pericholecystic, so when we're talking about the prefix chole, we're always talking about gallbladder. Peri means surrounding and cystic means fluid, right? So surrounding the gallbladder fluid. We're going to see this with a lot of our organs as we move through our pathology lectures. So pictures on the right side, our top picture there, we can probably assume that this is an earlier onset of cholecystitis. Our gallbladder wall is looking pretty thick. You can see a little caliper measurement right here. We're not actually seeing the measurement that's provided, but we can tell just from visualization that that gallbladder wall looks a little bit thicker than it should. We're also seeing some irregularities up in this portion of the wall here. Could be some pericholecystic fluid starting to accumulate right there. But overall, we see this large gallstone blocking that neck of the gallbladder, therefore resulting in a backup of bile and the gallbladder wall reacting. Picture on the bottom, this is definitely an emergent situation. Our gallbladder wall is extremely thick. We're seeing pericholecystic fluid. We're seeing very irregular sludge and debris in this gallbladder. So we would want to make sure in both cases to get immediate medical attention, but the picture on the bottom is a more severe case of cholecystitis. Okay, so when we're talking about cholecystitis, we're saying that this is a problem, right? And it can progress pretty rapidly. So we want to make sure that we know when to take the next steps in terms of immediate attention. When you are scanning an abdominal exam, particularly for right upper quadrant pain, you're looking for what we clinically term a Murphy sign. Now, this is not something that we talk to the patient about. This is not something that we kind of explain to the patient. It's something that we have to decide as a sonographer. Does this patient have this clinical sign or do they not? A Murphy sign, when you are scanning a patient and your transducer is over the patient's area of where their gallbladder is, and you're not necessarily applying a lot of pressure, but you're applying enough pressure to get your images. If that patient has excruciating pain when your transducer is touching the region of their gallbladder in their right upper quadrant, that is a positive Murphy sign. And this isn't the typical slight discomfort. It's not a little like wince or a whine. This is your patient is in physical agony while you are scanning that gallbladder. That is a positive Murphy sign. So when we're scanning, if our patient is content and they're talking or they're sleeping while we're scanning them, we're not stopping and saying, do you have pain here? Does this hurt you? On a scale of 1 to 10, what does this feel like? Because if you have to do that, that's not a true Murphy sign. So if you have a true Murphy sign, you are scanning that region of interest, your patient is in agony, unfortunately, and you're measuring a gallbladder wall of greater than 3 millimeters, that patient needs to go to surgery immediately. That gallbladder is on the brink of rupturing. If your gallbladder ruptures, that is going to lead the patient to potentially go into septic shock. So we need to prevent that type of situation from happening. Now, acute cholecystitis, this means the rapid onset of this inflammation of the gallbladder, right? So as we said on the previous slide, this is usually going to be caused by obstruction. Now, you can have a calculus type of obstruction, or you can have an obstruction that's caused from something other than a gallstone, and that's going to be an acalculous obstruction. That's going to account only for about 10% of cases of acute cholecystitis, and that's usually only going to be because there's some type of bacteria or parasite that is causing that obstruction of the gallbladder, therefore resulting in this acute onset of inflammation to the gallbladder. Clinically, very similar to the previous slide that we just said. Right upper quadrant pain, epigastric pain, back pain, pain after eating, that's postprandial pain. Prandial means eating. Abnormal LFTs, a positive Murphy sign, an increased serum amylase. So again, we need to be aware of what that Murphy sign is and if our patient has it or if they don't have it. Next, we have chronic cholecystitis. So this is when we unfortunately start to worry a little bit less. These patients, for some reason, keep getting these recurrent episodes or these attacks of cholecystitis. And after a period of time, your gallbladder can only do so much, right? It's like if you were a boxer and you're going all of these rounds in the ring and you just keep losing round after round after round. Well, by the time the last round comes around, you're done, right? You have no energy, you are spent. So that is what happens in these chronic cases of inflammation to organs. The organ kind of just like puts up the white flag and gives up by the end of the 10th round. So with time, in cases of chronic cholecystitis, that gallbladder is so weak and so tired from having to constantly respond to these episodes that it can allow carcinomas to come into the picture. It's so weak, it doesn't really have its own line of defense to protect itself as an organ, so cancers can kind of make their way in. So with chronic cholecystitis, we're not necessarily worrying about it rupturing at this point. We're more worried about protecting it from outside forces. Clinically, patient's going to be asymptomatic. They are so used to this. Their gallbladder is like, yeah, you can't hurt me anymore. They're going to have abnormal LFTs, increased serum amylase. On ultrasound, we can see those gallstones if that is what is causing this cholecystitis, or gallstones can actually form because of the cholecystitis. The gallbladder is going to be small in size. It's going to be in this kind of continually contracted state because, again, it can't function the way that it used to before. The bile is going to appear echogenic. We can see some sludge with that. And the wall is just going to be chronically thickened. Next, we have hydrops of the gallbladder. So this is something that we're actually not seeing too often, but when you are seeing it, it's pretty interesting. This is the abnormal dilation or dilatation, they both mean the same thing, of the gallbladder due to some type of obstruction in the cystic duct. The main cause is going to be, of course, our friendly culprit, cholelithiasis. When we have this abnormal dilation of the gallbladder due to that blockage further into the tree, the bile is actually going to get reabsorbed by the gallbladder itself, particularly by the gallbladder wall, and then it's going to refill itself with these like mucosal secretions from that mucosal layer of the gallbladder wall. And then this is the term that we give it, a mucocele. So if we look at our picture on the right side, on the bottom, we have this humongous gallbladder, right? And it's still appearing anechoic. So we know it's still some type of simple fluid, but at this point, it's no longer bile. The bile is getting absorbed by the gallbladder wall, and in its place, it is secreting these mucosal fluids from the wall itself. So it's kind of like this really weird give and take relationship because the gallbladder is trying to get the bile out somehow because of that cystic duct obstruction. So it's trying to exit the gallbladder through the wall. And in its place, we're getting these secretions from that mucosal layer. Clinically, it is a painless right upper quadrant mass. As you can see on that patient, obviously the patient is very thin, so on a much larger patient, we probably wouldn't be able to see or palpate that mass, but on a thinner or a younger patient, we would be able to see that clinically. On ultrasound, it's going to appear similar to a regular gallbladder, just massive. So it's going to be distended, it could potentially take on a rounded shape, and it's not going to be inflamed. So this isn't causing any type of inflammation or infection. We're not seeing a thickened gallbladder wall. We're not seeing pericholecystic fluid. So we're really just seeing an overwhelmingly dilated gallbladder. Next, we have porcelain gallbladder. So this is when we have the entire calcification of the gallbladder wall, most common in women over 60. I mean, we're really just lucking out with all of these conditions that we can get, right? Clinically, it's going to be asymptomatic, but it can be and is associated with cholelithiasis, of course. There is an increased risk of gallbladder carcinoma occurring from this. So this is usually kind of like an ominous, like, predecessor sign of any type of potential gallbladder carcinoma happening in the future. So usually if we see porcelain gallbladder, we are just removing that patient's gallbladder to prevent any type of precancerous or premalignant cells taking place. On ultrasound, we are going to see a thickly calcified wall with shadowing. Important to remember that this is not your wall echo shadow sign, right? We are not seeing a wall and then the echogenic stone and then shadowing. We are just seeing a calcified wall. So if we look at our examples on the right side, we have just wall with shadowing, and then we can even see the posterior wall with shadowing. If there were a stone in here, right? If there was a stone here for wall echo shadow sign, we would not see that posterior wall because of that shadowing from a stone. So kind of similar in appearance, but look for those minute differences. Next, we have an adenoma. So adenomas are very hard for us to tell the difference between a true gallbladder adenoma versus a polyp. And this is why we really follow anything that looks slightly solid and is non-mobile in the gallbladder, because we can't definitively tell. We can't definitively give the patient an answer if something is benign or potentially malignant down the future. So we're following these patients. We're giving a differential diagnosis. Could be an adenoma, could be a polyp. What is an adenoma? We've talked about them a little bit before. This is any type of benign growth that occurs from the functional tissue of a particular organ. So of course, the gallbladder can have an adenoma. With these, although they are a benign neoplasm, they can be precancerous. So just like porcelain gallbladder, if we're seeing something that we think is an adenoma, we're most likely going to remove it. If we see something that is a polyp, we want to make sure that it's not an adenoma, because adenomas can be precancerous. Adenomas are typically going to be larger than polyps, as you can see by this picture here. They're usually going to be in that greater than 3 millimeter ballpark. So that's why if a polyp measures greater than 3 millimeters, we're questioning it further. We are usually only seeing one adenoma at a time, which is slightly different from a polyp. Polyp, we're usually seeing 1, 2, maybe 3, maybe a bunch of them. When it comes to gallbladder polyps, we say neighbors are our friend. So we don't worry if we see diffuse gallbladder polyps. That actually helps our diagnosis. It's when we have one polyp that we think could potentially be an adenoma if it's on that slightly larger scale. Next, we have adenomyomatosis. This is one of my favorite things to see and to say. This is the excessive proliferation of those epithelial cells in the gallbladder wall. So they're really interesting, and I wish I could find a really good color picture of these. I have yet to find one. If I do find one in the meantime, I will put it on your Blackboard page. But on ultrasound, they are these little echogenic foci that sit within the gallbladder wall. They don't move, so they're not a type of stone, but they're also not a type of polyp. These are also going to give us what we call a comet tail artifact. So if you look at our pictures and you see those little regions where we have our echogenic foci, and you see they almost have like a little tail underneath them into the gallbladder lumen, that is the collection of this excessive epithelial cell accumulation. So I'll see if I can find a really interesting color picture where it's showing us our comet tail artifact. We're typically going to be seeing multiple of these little echogenic foci with the little tails on them. We're usually not just seeing one. We can just see one, but we're usually going to be seeing it kind of occurring along the entire border of the gallbladder wall. These are also gland-like formations that have these little outpouchings of the mucosal layer. So that's where those cells kind of get trapped in between those layers of the gallbladder wall. Next, we have cholesterolosis. So similar to adenomyomatosis, this is when we have too much cholesterol or triglycerides that just get accumulated in that gallbladder wall. So again, we have this excessive kind of cellular accumulation happening, but this is different from adenomyomatosis because this is particular to excessive lipids, fatty cells, cholesterol, so on and so forth. So this is also known as strawberry gallbladder. As you can see that picture at the top, that's exactly where it gets its name from. It gives a spotty appearance due to these tiny yellow specks. Those yellow specks are actual fat cells, right? That's the cholesterol that is accumulating in that wall of the gallbladder. So we can see where it's getting that strawberry appearance from. Clinically asymptomatic. Some patients can have dull epigastric pain or right upper quadrant pain, but usually not anything that's going to be bringing a patient to an ER. It's usually going to be an incidental finding when we're doing an exam for some other reason. So on ultrasound, we are going to see a non-mobile, non-shadowing echogenic areas along the gallbladder wall. They could be variable in size due to how much cholesterol and fatty cells are accumulating in one particular region. So if we look at our picture on the bottom right side, we have a pretty large accumulation happening here. But then if we look a little bit closely, we have little accumulation, right? So it all depends on how much of this excess is accumulating in which region. But we are not getting any comet tail artifacts. We are not getting any type of tail posterior to this accumulation. Next, we have primary gallbladder carcinoma. So now we're getting into our malignancies of the gallbladder itself. This is extremely, extremely rare. We don't really see gallbladder carcinomas too often. For it being rare, it's actually going to be the most common biliary malignancy. So that's talking about our whole biliary system in general. We're really not seeing a lot of gallbladder or bile duct malignancies, but if we are seeing it, it's most likely going to be a primary gallbladder carcinoma. These are going to be the ones that are associated with that porcelain gallbladder. And we also, if we have primary gallbladder carcinoma, it is going to metastasize to the rest of the body by the lymphatic system or by our blood vessels. But its first stop and its main stop is going to be into the liver. And as we know, once we have metastatic spread into the liver, pretty unfortunate for our patients. It can go, it can pretty much spread like wildfire from the liver. Again, most common in women, 50 to 80. Clinically, it's going to be asymptomatic, but some patients will have weight loss, loss of appetite, nausea, vomiting, right upper quadrant pain, potential right upper quadrant palpable mass, and jaundice, depending on if there's any biliary obstruction. On ultrasound, we're going to see a solid mass occupying the gallbladder lumen. We could see a thickened wall, and that mass is going to be echogenic with irregular borders. So let's take a look at what that can look like. So here we can see, especially this first picture on the left side, you're automatically going to think that there's something weird going on with that gallbladder, right? Does not look like cholelithiasis, does not look like those pictures of polyps or adenomas that I showed you before. But if we want to take it a step further, look how irregular the walls of this mass are. Right? It also has a little calcification here. It also has this area that looks hypoechoic, and this area looks hyperechoic. So it's heterogeneous. This picture in the middle, this could be where you could potentially get confused when you are scanning, especially as a student. You could be sweeping through that region and be saying, I don't see the gallbladder. Is the gallbladder just completely contracted because the patient ate? Did they have their gallbladder removed? Is this a wall echo shadow sign? Why am I not finding this gallbladder? You are finding the gallbladder. The entire gallbladder lumen is filled with this mass. So you're not seeing that classic appearance of the gallbladder that you're used to seeing, right? Distended, anechoic, elongated. You're not seeing any of that. So you can't rely on your background knowledge to help you find that gallbladder when this is what your gallbladder looks like. So you have to say, okay, I'm in my main lobar fissure. I know this patient did not have their gallbladder removed. What else can I be looking for? And then here we're putting color on it just to prove that there's vascularity to that mass. We can see our vessel right here feeding it. Next, we have metastatic disease that has spread from elsewhere into the elsewhere of the body into the gallbladder. So again, very rare. The gallbladder is not usually going to be a site that cancer spreads to. It's typically when patients have really severe end-stage cancer elsewhere in the body. They could not be doing any treatment. They could, just be letting their life take their natural course. And unfortunately, those cancer cells have somehow finally made their way to the gallbladder. The most common primary that is going to spread to the gallbladder is going to be melanoma. Clinically, the patient will be asymptomatic or have symptoms of whatever type of malignancy they currently have. They could have similar symptoms to cholecystitis. They also could have jaundice. On ultrasound, these lesions are usually going to appear about 1 centimeter or greater in the gallbladder lumen, and they are going to appear as echogenic and usually hypoechoic masses in that gallbladder. And you can also see these two bottom pictures very easily could confuse that with a polyp or an adenoma. So again, we're not taking polyps and adenomas at face value. We're always doing a little bit more interrogation just to make sure we're crossing all of our T's, dotting all of our I's. Next, we are moving into our biliary tree. So I want to talk about jaundice first, just a little bit. So this is something that usually is going to affect the liver because of something going on in the biliary tree. So jaundice is not specific to one type of organ or organ system. It really is something that can occur when this working relationship between the liver and the biliary tree are not working properly. So it's a significantly abnormal bilirubin levels in a patient, typically caused by blockage somewhere along that biliary tree. Obviously, that blockage is most commonly going to be caused by some type of gallstone located at some point of that biliary tree. I should specify this. Gallstones that are located in the biliary tree are no longer called gallstones, and we'll talk about that. But if we have a gallstone that is blocking the neck of the gallbladder, that is the most common cause of jaundice. Okay, so we're still in this scenario considering the gallbladder itself to be part of that biliary tree because it is. I would just like to specify that if a stone is located in a bile duct, it is not considered cholelithiasis. And we will talk about what it is considered in a second. Clinically, patients who have jaundice are going to have yellow skin. They're going to have pruritus, that is itchiness of the skin. They will have right upper quadrant pain, weight loss, dark urine. On ultrasound, we could see a dilated gallbladder, an enlarged liver, a CBD that measures greater than 7 millimeters in a patient who has not had their gallbladder removed. We can also see numerous visible tubes traveling throughout the liver. That is going to represent dilated bile ducts. We could see the double barrel sign, and we could also see irregular biliary walls. So we're going to talk about jaundice in a lot of these conditions. So I just wanted to give a little brief recap on what that is. Ductal dilatation. So we have all of these bile ducts that travel throughout our liver. We've talked about our main ones, right? Our common hepatic duct, our cystic duct, they join to form our common bile duct. But as we branch out into the liver, or rather as our liver branches into our biliary tree, we have all of these small little bile duct branches that are draining all of those fluids from the liver. So those ducts that travel in the liver are going to run parallel to the portal veins and all the small portal vein branches. Now the ducts that are located within the liver, they are going to be considered intrahepatic ducts. They should be really small, so they should be measuring less than 2 millimeters. And because they are that small, we are not going to be able to routinely visualize them on ultrasound unless they are dilated. The only time we're really going to see those small bile ducts is if there's something wrong and if they are appearing dilated to the point where they are measuring 4 millimeters and greater. Now, the common hepatic duct of the liver, as we know, it's going to join with our cystic duct to form our common bile duct. Our common hepatic duct, if it measures 6 millimeters, that needs further investigation and evaluation. If our common bile duct measures 10 millimeters, that needs further evaluation. So depending on where you are located in terms of a duct, a bile duct, that is going to determine what is considered normal or abnormal. All right, our first one of our biliary tree is Merizi's syndrome. So this is a really interesting condition for us, not for the patient, rather painful for the patient. This is when we have an extrahepatic biliary obstruction. So this means we are talking outside of the liver. Okay, we're not talking about the bile ducts in the liver. We are talking about the bile ducts outside of the liver now. So this is when we have a gallstone that's impacted at the neck of the gallbladder or is actually located within the cystic duct. And that's not necessarily the problem with Merizi syndrome, right? Because we kind of just talked about that in our gallbladder pathology. The problem with Merizi syndrome is you have this gallstone that is impacting the neck of the gallbladder, but it's pushing across and compressing on the common hepatic duct. So now you have an obstruction in the common hepatic duct because of an obstruction in the cystic duct. So that is what Merizi syndrome is. When you have just a gallstone obstructing the neck of the gallbladder, that is when we can have cholecystitis. That is when we can have hydrops, right? This is when we have that stone in the cystic duct or the neck of the gallbladder, and because of that obstruction, it's going to be pushing adjacent to it and compressing that common hepatic duct. Clinically, the patient's going to have pain or fever. They could have edema of those biliary tissues and inflammation of those biliary tissues. As we know, any inflammation is not good because that can lead to tissue death in a long-term sense. On ultrasound, we are going to see dilation of the duct above the level of the stone, and then the duct will appear normal below the level of the stone. So if we look at our example here, we have our gallbladder with a bunch of cholelithiasis in it. This stone has gotten lodged in that cystic duct, right? Here's our cystic duct. And because of that, it's now compressing on that common hepatic duct. But if we look at the level above that obstruction, this is going to be a dilated common hepatic duct. This is a dilated cystic duct, but below the level of the obstruction is going to appear normal. So this common bile duct is still going to appear normal. We could also see cases of cholecystitis with this, obviously, because as we know, we still have that stone that's lodged and obstructing the gallbladder. And then we can have segmental stenosis of that common hepatic duct. So that's really what we're talking about when we're talking about the compression of the common hepatic duct. We are compressing that lumen of the duct so nothing can travel through it, and we're creating a stenosis because of that. Next, we have Caroli's disease. So this is a type of biliary dilation that is not caused by an obstruction. So we're not talking about gallstones with this, surprisingly. This is also known as communicating cavernous dilation, and it's considered a congenital abnormality. So we're seeing this in younger patients, typically going to be common in people younger than 30. So we're seeing this in a lot of kids and early adulthood. Clinically, the patient's going to present with potential right upper quadrant pain. They could have biliary stasis because their bile doesn't really know where to go because everything's so dilated. It can't really ever find the correct pathway out. So we're going to have biliary stasis because of that. That can lead to stone formation. Anytime we have biliary stasis or stone formation, that can also lead to inflammation of the bile ducts. That's going to be our cholangitis, and also sepsis eventually if this goes untreated for too long and the biliary system can't function properly. On ultrasound, we're going to see a beaded appearance, and this is representing these saccular little dilations of the biliary tree. This is where a lot of our sludge can kind of accumulate. This is where our stones can accumulate, and these are going to be our irregularly dilated segmental portions of those intrahepatic ducts. So we're talking about inside the liver now. If we look at our diagram on the top, this is a really good representation of that. So here we have where our liver would be, right? Our gallbladder and our cystic duct are going to be considered extrahepatic because they're not actually draining the liver of bile. They're only responsible for the gallbladder itself. So if we look at the intrahepatic biliary network, we see all of these saccular outpouches of the biliary tree. So the bile is going to be trying to travel through these and kind of get confused, right? And it's almost like the teacups ride at a carnival where they don't really know, or like a fun house at a carnival where you don't really know what is the normal pathway and you're getting confused by all of the mirrors that are trying to point you in a different direction. So the bile is never really going to know how to fully exit, and therefore that biliary tree is not going to be functioning as well as it should. Next, we have biliary atresia. This is something that is more of a fetal condition. So this is something that we want to be aware of when we are scanning babies or we are scanning newborns. This is the absence of the extrahepatic biliary tree. So we don't have a gallbladder, we don't have, or we have a gallbladder, but we don't have a cystic duct, or we don't have a common hepatic duct, and therefore we don't have a CBD. So we're missing some component of the extrahepatic biliary tree, if not all of it. This means that the bile is going to be unable to pass from the liver, that should say, to the gallbladder. So therefore the bile is going to start to build up within the liver, and that's going to have an effect on that liver tissue and function as well. Clinically, infants are going to present with jaundice and alcoholic stools, and that's because that liver is now trying to process all of that excessive bile. It also can be associated with cases of what we call situs inversus. Now, situs inversus, you may have heard of this before, but this is when you are congenitally born with your organs positioned on the opposite side of your body than where they should be. So your liver, instead of being on your right side, is now on your left side. And your heart, instead of pointing to the left side, is now pointing to the right side. And your organs are almost a mirror position of the way that they should be. We're going to learn more about situs inversus when we get to OB. This condition can be fatal, right, because our biliary tree can't function and therefore our liver can't function, and it can kind of put the liver into damage. We can have a lot of liver damage because of it, and therefore can develop cirrhosis as well. Ultrasound, we're going to see missing components. So we're going to see a missing CBD, or we wouldn't normally see a cystic duct or common hepatic duct anyway, but if we don't see a CBD, we know that something else is going on. We could potentially not even see a gallbladder, or the gallbladder that we do see can be very, very small. We also are going to see only those two vessels in the porta hepatis, right? So we're only going to see that main portal vein and the hepatic artery. Also, as we're looking throughout the liver tissue itself and we're looking at the portal triads throughout the liver, we know that our bile ducts should be traveling with a portal vein. So if we don't see that and we only see portal veins, then again, we know that something else is happening here. So this is a picture here showing our main portal vein here, hepatic artery here, and this is where our CBD should be. Next, we have a choledochal cyst. So this is a cystic dilation of the common bile duct, typically in the common bile duct, but can be located anywhere in the biliary tree. The biliary tree is going to be the most common. All right, so literally just take back the last 5 seconds that I said. Most commonly going to be located in the biliary tree, but can occur in the CBD specifically as well. It can be congenital, and we can either see this as just one choledochal cyst, or we can kind of see this throughout the entire biliary tree itself, meaning in multiple different locations. It's going to be most common in younger Asian females. Clinically, they're going to be asymptomatic. We could see a clinical triad of jaundice, right upper quadrant pain, and a right upper quadrant mass, depending on the location and the size of this choledochal cyst. We also could see the patient representing increased bilirubin levels. On ultrasound, we are going to see an anechoic mass adjacent to the gallbladder at the porta hepatis. We could see a dilated CBD or hepatic duct, because as we know, we should not be seeing the common hepatic duct unless there's something wrong. The cystic duct may also be seen entering the cystic component of the choledochal cyst, and it is going to be absent of blood flow. So we're technically considering this to be a mass when really all it is this focal cystic dilation of a particular segment in the biliary tree. Now, we can have multiple choledochal cysts, but we want to make sure that we are not confusing that with Caroli's disease either. So a lot of these can take on very similar appearances with each other. So if we look at our picture, we have our gallbladder here, and then we have our choledochal cyst here, and this is occurring somewhere along that biliary tree. Not very common for us to scan choledochal cysts. On the other hand, choledochal lithiasis is pretty common for us to be scanning. This is when we have a stone that is located within a bile duct, most commonly going to be located in the distal CBD near the pancreatic head. This can be secondary or primary. A primary case of choledochal lithiasis is going to be when the stone forms within the duct itself, and that's caused due to biliary stasis. So that bile has slowed down, it's not traveling through that CBD as well as it should, so it's kind of accumulating. And then we can have a secondary. So this is going to make me seem like a big fat liar. And this is when stones form within the gallbladder and then pass through the gallbladder into the cystic duct, therefore into the common bile duct. This is not likely. This is something that is extremely rare. This is something that usually only occurs with very small gallstones, like those gravel gallstones that we were talking about. We are usually seeing primary choledochal lithiasis. We are seeing that the stone is actually forming within the duct itself. It's not coming from somewhere else. But you have to know that it is possible. It's just not likely. Clinically, it's going to have an increase as we age of getting choledochal lithiasis. We are going to see increased levels of bilirubin, alkaline phosphatase, abnormal LFTs. Patient can have leukocytosis depending on the severity and any other complications that this stone is causing. On ultrasound, we're going to see that echogenic foci in the extrahepatic duct, right? So we're not looking in the liver at this point. We are looking at our CBD, which is located outside of our liver. And we're going to see ductal dilatation depending on the size of that stone and the location of where it is positioned. And this is a really nice example, all labeled out for you. Next, we have cholangitis. So this is when we have infection and inflammation of the biliary ducts. This is going to be caused by, of course, some type of stone or an interventional procedure. So this is something that we need to be aware of the patient's medical history, just to see, have they had anything recently that could have introduced some type of infection into this patient, therefore affecting their biliary tree. Clinically, it's going to be associated in patients who have IBS and UC, ulcerative colitis. These patients are going to have typical symptoms of an infection or inflammation: fever, abnormal LFTs, jaundice, right upper quadrant pain. On ultrasound, the biliary wall is going to appear thickened. Remember, not the gallbladder wall. This is not the gallbladder. This is the biliary wall. So this is going to be the CBD is going to appear thickened. Next, we have ascariasis. So this is, it's absolutely disgusting. This is a parasitic disease. It's really uncommon to the US, thankfully, also known as a roundworm. We can get this parasite by ingesting eggs of contaminated food and water. So like these eggs just hang, these like worm eggs just hang out in food and water sources. So we're very grateful to have healthy, safe drinking water. Clinically, the patient, I don't know, I have no idea how these patients would be asymptomatic, but they can be. They are also going to have abdominal discomfort, fever, nausea, vomiting, diarrhea. The good news is these are very easily treated with medications. You go on a very heavy antiparasitic medication and it kills anything in your system. And then you pass that naturally. On ultrasound, we are going to see these things moving in there. It's like, it just like, I don't know, like some people can't do poop, some people can't do vomit. I can't do like worms and stuff. Ugh, parasites. They're going to appear echogenic. They're going to be very tubular in their structure with a hypoechoic central portion. I do have a video in our module, I believe. If not, it's in the liver one and you have probably already watched it, but you can see how they actually move in lifetime. Next, we have hemophilia. So this is when we have an accumulation of blood within the biliary tree, and this is not something that really occurs spontaneously. This is something that is usually going to occur after a patient had some type of interventional procedure done. So did they have a liver biopsy and maybe we nicked one of the vessels and now we're bleeding into the bile ducts? There are a bunch of different things that can result in hemophilia, but naturally occurring hemophilia is not necessarily going to be a thing. So usually going to be caused by some type of interventional procedure. If the patient has any type of malignancy as well in the biliary tree, the gallbladder, or the liver, malignancies have vascularity to them, right? So if we have these feeding vessels that are supplying a malignancy, well, they can start to bleed. So we can have that bleeding accumulating in the biliary tree. Also, any cholangitis or cystitis, so the inflammation of the biliary tree or the gallbladder itself, can result in bleeding of those tissues, and that can accumulate in those bile ducts as well. Clinically, patient is going to have pain, jaundice, and they are going to have, depending on the severity and the cause, they could have internal and external bleeding. So we could see bleeding. Of course, if they had some type of intervention, they're going to have some type of entry wound on their body, right? So we can see that blood coming out of that, but we can also see blood starting to really, really pool in that biliary tree, and therefore causing, a more severe type of internal bleeding. On ultrasound, depends on how old the blood is and how old the bleeding source is. Acute blood is going to appear as hypoechoic, and as it gets older or more chronic, it starts to dry up and becomes hyperechoic. Next, we have pneumobilia. This is when we have air within the biliary tree. This is going to be caused by, of course, cholelithiasis and chronic cholecystitis, but also when we have a biliary enteric fistula. So this means that we have an abnormal communication between our biliary tree and our digestive tract. So we can kind of have like this type of like direct communication of like fecal cells and bacteria that can go into our biliary tree because there's this abnormal communication and connection between the two when there shouldn't be. So that can kind of cause a lot of this like infectious process. Anytime you have an infection, that infection or an abscess, anytime you have these like bacterial or parasitic or infectious or viral cells that are accumulating in your body, they can always produce gas. So that would be this case of being caused by an infection, having this pneumobilia. You have this biliary enteric fistula. You have this exposure to these bacterial cells from the digestive tract. So that's getting into your biliary tree and it's kind of creating this gas byproduct because it shouldn't be there, right? So it's creating this infection in that biliary tree. That infection is producing like this gas byproduct and we're seeing that gas. That is that air within the biliary tree that shouldn't be there. On ultrasound, it is going to appear as echogenic linear foci within the intrahepatic tree. So the air is going to follow the shape of the bile ducts. It's going to go where it can. It is going to change with patient position. So air, as you know, kind of like an air bubble, they're always going to float up to the top. We are going to see shadowing, as we know with air, it typically shadows for us, and we could see ring down artifact as well if we were to put color on those air bubbles. Next, we have cholangiocarcinoma. So again, we're still talking about the biliary tree. That's going to be our key prefix term when we are studying for our registry. This is a very rare type of malignancy and it's specific to the bile ducts. It is a type of adenocarcinoma. So adenocarcinoma is just like adenomas. Adenoma is the benign proliferation of organ tissue. Adenocarcinoma is the malignant proliferation of that functional tissue of an organ. So this is a type of adenocarcinoma. And this is a cancer that actually occurs in the mucus secreting glands. So we see a lot of adenocarcinomas occurring in organs that kind of produce secretions, and our biliary tree obviously is one of them because it produces bile and secretions of that sort. This is typically going to occur in either the common hepatic duct or the common bile duct. And because of that, we can have like these different locations. We classify these cholangiocarcinomas by those locations. So is it an intrahepatic cholangiocarcinoma? That means it's occurring in the common hepatic duct. Or is it located right at the hilum? Right? So it's kind of right at that early CBD position. That's going to be a hilar cholangiocarcinoma, also known as a Klatskin tumor, which we'll talk about again in a second. Or is it located like totally extrahepatically? It's very distal. It's at the distal CBD, closer to the duodenum and the pancreas. That's going to be a distal cholangiocarcinoma. Clinically, these are going to have a prevalence in Japan and Thailand. Very interesting, like statistics that come out of a lot of these pathologies. I'd be interested to see more information on it if any of you guys want to do a research project on some of these pathologies. Risk factors: anyone who has chronic biliary stasis, biliary inflammation, infection, or stones. On ultrasound, we are going to see a solid mass located within a biliary duct. So if we look on our picture here, we have our extremely dilated CBD. So right here we have main portal vein, hepatic artery, and super dilated CBD, right? Even to the point where like we're seeing that CBD like dilation and extension all the way intrahepatically. So we know that this tumor is really causing quite the obstruction. Now we follow that CBD all the way down and we get to this region of the yellow arrow, and this is all a tumor that's occupying that space of the CBD. So this would be a distal cholangiocarcinoma. Now let's talk about a Klatskin tumor again. Just a little bit more detail with this. As we know, this is a type of cholangiocarcinoma. It's typically going to be located at the hilum of the liver, so right at that porta hepatis, and it's going to occur at the bifurcation of the right and left hepatic ducts. So right when that common hepatic duct diverges into the right and left hepatic ducts, that's usually where this is going to be positioned. So right at that entrance of the liver is where we are going to see that type of cholangiocarcinoma, and that's where it gets its term a Klatskin tumor. Now, I actually did scan a Klatskin tumor not too long ago, and you can see here not the best picture of these images in terms of the relationship to the porta hepatis, but this picture on the right side, you can see I'm like kind of right at the border. Here's my liver border, liver, all this, right? This. So I'm right at the porta hepatis, but I'm also extrahepatic. So we would still consider that a Klatskin tumor because it is at the hilum of the liver, even though it's not at the junction of the right and left hepatic ducts. So very interesting case. This was the first time I had seen something like this in my career. We see a lot of choledocholithiasis where we see stones in the bile ducts, but I've never seen an actual solid tumor in the bile duct itself. I've never seen a cholangiocarcinoma of any sort. So great thing to kind of keep in the back of your mind. All of this stuff we need to be aware of. 5, 10, 15, 20 years down the road, these cases are going to keep popping back up. Even these rare cases are going to keep popping back up in your experience. So any questions, please feel free to reach out to me. Make sure you understand the difference between types of words. Cholecystitis, gallbladder. Cholelithiasis, gallbladder. Choledochal cyst, biliary tree. Cholangiocarcinoma, biliary tree. So get that terminology down, and once you have that, that should help you to remember things a little bit easier.